So, in this lecture, we're going to talk about mood disorders. And when I ask you to think about mood disorders, what comes to mind?
Bipolar disorder.
Bipolar disorder. Good job, Chastity. Are there any other conditions that come to mind?
Depression.
Unipolar depression, or since we said bipolar depression, we'll say unipolar depression. And the technical term for depression is major depressive disorder, and that is to be compared against uh, bipolar disorder. I see in the chat someone said multiple personality disorder. That is not a mood disorder. That's actually a dissociative disorder. So, dissociative identity disorder is the technical term for multiple personality disorder. But
Um, oh, sorry.
yeah, go for
I
it.
think this is more of like a symptom, but like lack of sleep and like energy and stuff.
Sure, there's lack of sleep as a symptom. And if we were to think about mood disorders, there are long-term conditions as well. So we talk about persistent depressive disorder, which is what we used to refer to as dysthymia or dysthymic disorder. And the bipolar parallel is cyclothymia, right? So there are other mood disorders other than major depressive disorder and bipolar disorder. And there are disorders that you probably have heard of as seemingly distinct, but in reality, they're specifiers to major depressive disorder. How many of you have heard the concept of seasonal affective disorder? Anyone ever hear that term? Seasonal affective disorder? Okay, I see. In reality, the proper terminology for seasonal affective disorder is major depressive disorder with seasonal onset. Anyone ever hear of postpartum depression or postpartum blues? So, in reality, postpartum depression is major depressive disorder with postpartum onset. So, in addition to having these general classes of disorders, we also have subtypes of the disorders or specifiers. And I think that's important. Now, the DSM 5 did add an additional disorder called premenstrual dysphoric disorder. And we'll talk about that shortly. But premenstrual dysphoric disorder refers to mood changes that occur more often than not in the lead up to one's menstrual cycle. And as one has their menstrual cycle, the symptoms of the condition subside within that week. So the rates are relatively low in terms of diagnosis. So I think that we'll talk about what that might imply when we get there, though. So that's when I talk about mood disorders, that's kind of giving you a little bit of a flavor of some of the unipolar and bipolar mood disorders that we will discuss. But let's start with unipolar conditions, right? So if we were going to talk about unipolar mood disorders, you can talk about a major depressive episode. Now, a major depressive episode is a single depressive episode that lasts for a minimum of 2 weeks or longer and has a whole host of symptoms. And you know, we will go through the symptoms, but I know one of your peers mentioned sleep. There are sleep changes, there are appetite changes, there's lack of motivation, lack of concentration, perhaps suicidal ideations, and so forth. Now, a major depressive disorder is when there is at least one depressive episode. So when we diagnose major depressive disorder, we would say major depressive disorder, single episode, moderate severity, or whatever the level of severity is. If a person has had an experience of a major depressive episode in the past, we would say major depressive disorder recurrent type, and then however the level of severity is. So that's what an episode is and what the disorder is. Now, notice we specify whether this is your first episode or whether it's a recurring situation. I also mentioned that we have something called persistent depressive disorder, and that used to be referred to as dysthymia. Now, when we talk about persistent depressive disorder, we are talking about long-term or chronic depressive symptoms with lower levels of severity. So in order to get the diagnosis of persistent depressive disorder, a person has to have these features for a minimum of 2 years without a break of 2 months or longer. Now, I said these are examples of unipolar mood disorders. Notice that in order to be diagnosed with any of these, you cannot have any history of a manic episode or even a hypomanic episode, which we'll talk about later. So we talked about what depressed mood is, but a manic episode is more of a elevated mood, perhaps feelings of euphoria, feeling of like you're on top of the world, lots of energy, decreased need for sleep. And all of these symptoms sound really great, most people would say. But what's the problem with being in a manic episode? Well, there's also increased impulsivity and risk-taking behavior. So there could be impulse buying or spending. There could be impulsive substance-related issues. There could be impulsive sexual activity. There could be impulsive or reckless driving. And so if it were just the positive features, maybe it wouldn't be such a big deal, but the impulsivity and the reckless behavior that can occur as well, that's why a manic episode is concerning. All right, so let's get into it. Unipolar depression, as I said, is depression in the absence of a manic episode or a hypomanic episode. You cannot have a history of mania or hypomania. The question in the chat was, do people who are going through a manic episode realize it? Sometimes yes, sometimes no. I would argue in earlier phases of struggling with a condition, a person may not realize that they're engaging in risky behaviors or manic behaviors, but through time, they may start to say, okay, there's something off. I have increased irritability, I have increased impulsivity. Sometimes I spend beyond my means in a way that puts me at risk of not being able to pay my bills. So through time, Chastity, people do realize that there's this impulsive nature and reckless nature that creates some risk. Not in the beginning, though, not necessarily. So unipolar depression, it's important to distinguish between what people describe as, oh, I'm so depressed, versus actual diagnosis of depression. Depression is more than just feeling sad or more than just having the blues. Day to day, it's possible for a person to feel sad or down. But in order to have a major depressive episode, as I said, it has to be longer lasting. And at a minimum, the symptoms have to last for most of the day, if not all day, for 2 weeks straight. So it's not just, oh, I got a bad grade, so now I feel sad today, or I, heard something on the news that's disturbing, so now I feel sad today. It has to be an ongoing issue. So I would argue people use the word depressed in a careless way and in a non-diagnostic way. So it's more than just feeling sad. So what is the epidemiology of unipolar depression? It's about 1 out of 14 people in a given year will be diagnosed with depression. And it's about 1 in 6 people across their lifetime. So depression is the second leading diagnosis people have, only trailing anxiety disorders. It used to be that depression was the #1 disorder of diagnosis, but anxiety disorders have surpassed it. So it's fairly significant. Now, we know depression can occur at any age, but more often than not, it occurs in early to mid adulthood. And that's when some of the real pressures of life related to work, settling down, finding a romantic partner, and finding meaning in one's life those pressures start to add up. So it shouldn't shock us that it's early to mid adulthood, so our 30s to 40s. We also know that females are 2 times more likely to be diagnosed with major depressive disorder. And this fits the general framework we've talked about, that mood and affective conditions tend to be higher diagnosis rates amongst females, whereas cognitive-based disorders tend to have higher rates amongst males. So this fits that pattern. Now, is this disparity exclusively due to women being at higher risk for depression? No. I would argue that some of the difference in diagnosis is also a referral bias, and females are more likely to enter treatment than males in general, more likely to show emotional vulnerability than males in general. So some of the difference is more social, but that doesn't explain the whole difference. Now, how long is a person going to be carrying the weight of depression? Well, depressive episodes, first of all, sometimes they can recover without treatment, but in general, we see about half of the cases subside within a month and a half, right? And 90% of the cases within a year. So even though the minimum threshold is 2 weeks, it can last longer than 2 weeks. And that's important to note. So as clinicians, we know depression affects 5 different domains. So it's going to affect one's emotional well-being. It's going to affect their motivation, their behavioral actions, cognitions, and then their physical experience. So let's go into it. When I say depression affects one's emotional well-being, depression, the emotions that we're talking about are feelings of sadness, which is the prototype, but it could also be feelings of emptiness or misery or humiliation. It could also be a reduced sense of pleasure in day-to-day activities. So people with depression sometimes who, let's say they enjoyed an activity, they enjoyed doing art or drawing artwork. It's possible that they will not enjoy it as much in the midst of a depressive episode. Now, there are people who report having the loss of the experience of pleasure altogether, and that's what we refer to as anhedonia. And that's a more extreme case. Most of the time, it's I'm not getting as much pleasure in activity as I used to. When we talk about motivation, we see motivation is linked to one's drive, right? So some people have a strong drive for accomplishment or achievement, and that motivation drops, the drive drops, initiative drops. So, okay, I'm at work, I'll do what I'm told, but I'm not going to go out of my way to do anything that I'm not asked. Spontaneity, which is doing things as they come into your mind. There's reduced spontaneity. So we see motivation is an issue here. And when it comes to the lack of drive and the lack of feeling one's purpose, suicide tends to be an option, right? People sometimes decide to, end their own life. And we see anywhere between 6 to 15% of people with depression die by suicide. So as a way of dealing with the problems. Now, from a behavioral point of view, people tend to be less active and productive. So when we talk about behaviors, we're looking at actions and observable outcomes, right? So less activity, less productivity, slower speech. People, when they're depressed, they can become more lethargic, but their speech slows down. We see increased amounts of time in bed. Now, we're not talking about actual sleep, but one of the behavioral challenges people have is getting out of bed. So a person could be awake and staring at their ceiling for hours because they just don't have the energy to get out of bed. So that the weight of the covers feel all that much heavier when a person is depressed. We also have cognitive symptoms of depression. So things like negative self-perception. So a self-perception is exactly that, how you view oneself. It oftentimes, people can be overly critical of themselves. People can also be pessimistic in terms of expecting the worst to happen. And then in terms of like raw cognitive abilities, there's decreases in memory, attention, concentration, and so forth, all linked to depression. And it's interesting, when I teach about ADHD, I mention this point that people have cognitive deficits, not just when they're experiencing ADHD, but depression can mirror ADHD in some ways. So if a person's more distractible, their memory, they don't seem to be holding on to things as well, it could be that they're in the midst of a depressive episode. So we have to rule out depression as well when dealing with ADHD. Now, physical symptoms, some of the physical symptoms are similar to physical symptoms in anxiety. So things like headaches, indigestion, constipation, physical pain, right? These are all symptoms that could be reflective of anxiety or depression. But there are significant other physical issues, things like changes in sleep. And I want you to attend to the language, changes in sleep. Because when a person is depressed, it's possible that they might sleep more than usual, or they may struggle sleeping altogether. So if you have a person who's averaging 7 hours of sleep, and then they're in the midst of a depressive episode, it's possible for them to average 9-10 hours because they're depressed, or 4 or 5 hours. That same issue could result in less sleep. We also see changes in eating. And again, the word changes is important because some people when they're depressed, overeat. So they start to eat more than usual. And some people, when they're depressed, struggle to eat altogether. So they lose their appetite. So these are the 5 domains. Now, we also have to talk about libido. So with depression, another physical feature is decreased sex drive. And when we talk about sex-related disorders, anxiety and depression account for performance issues, or a lot of the psychological performance issues related to sex. So when we talk about erectile dysfunction, people who have severe depression are going to be at greater risk of erectile dysfunction. People with severe anxiety are going to be at greater risk for erectile dysfunction. So not only does it affect the physiology, but it also affects the urges themselves, the desire. So that's depression as a piece of it. So let's take a look at it. We talked about diagnosing major depressive disorder. You need to have a minimum of 2 weeks of 3 or 4 of the following symptoms. Now, I went through a whole lot of symptoms. You don't need all of them, but things like depressed mood, decreased pleasure, changes in weight, sleep, energy, sex drive, feelings of guilt, suicidal ideations, hallucinations, and delusions. Now, that is an interesting one, isn't it? The last 2 symptoms are not common, but they can occur. So if a person has a severe depressive experience, it can also induce some psychotic states. Now, I mentioned to you about postpartum depression, or what we diagnose as major depressive disorder with postpartum onset. Has anyone ever heard of the person by the name of Andrea Yates? Has anyone heard the name Andrea Yates before? I see in the chat a bunch of no's. Well, I'll describe what happened with her, and maybe this will help make a little more sense. So Andrea Yates struggled with mood for her whole life. And her husband, and her 5 kids were living down in Houston, Texas. And her husband worked for NASA. And one of the issues was related to medication management. She was on her meds, off her meds, a bunch of things like that. But in the midst of a depressive episode, she started to develop psychotic features. And she started to become religiously preoccupied about the safety of her kids, and whether her kids are going to wind up in heaven, or whether they would wind up in hell. And at a certain point in the midst of a psychotic state during depression, she came to the conclusion that the only way she could protect her kids was to drown them. And she called each child in for a bath one by one and drowned all 5 of her kids. And that is an extreme scenario, but this was a case of psychotic features linked to mood disorder, right? So it's rare, but when it happens, it can be catastrophic. So I encourage you to look up the case of Andrea Yates in your spare time. There's a lot more to it. If this were a forensic psychology class, I would be talking about the legal process as well. But you can look that up on your own. So, as I said, this is actually a typo. You don't need 5 features. It's actually 4 now. You need, in addition to sadness. So technically, I guess it is 5. So 2 weeks of the symptoms, no manic episode, no physical condition explaining these symptoms. Are there physical conditions that make a person feel more lethargic or might make a person appear depressed? And if so, can you give me one? Anyone have a sense of other conditions that might mimic depression? All right, well, dissociation. So dissociation is another psychological disorder. I'm talking about a physical disorder. So what is a physical condition that might mimic some of the features of depression?
Anxiety.
Anxiety is a psychological disorder. Now, we do have to rule out whether it's an anxiety disorder or a mood disorder, but how about things like hypothyroidism? Hypothyroidism is a good example of a physical condition that appears very much like depression. Now, does that mean that you can't have hypothyroidism and depression? Of course, you could be diagnosed with both, but if that's the case, you need to have enough evidence to diagnose the depression independent of the thyroid disorder. Another example is low blood sugar. Yeah, that's a good example. So glucose related conditions can appear like mood conditions. Multiple sclerosis can appear like a mood disorder. There are a lot of them. So when we come to a psychological diagnosis, we have to be very careful not to misdiagnose or overdiagnose something that's better explained by a physical condition. Now, to complicate things, as I stated, it is possible for people who have hypothyroidism to also have depression, right? So it isn't that it's one or the other. It's possible to have both, but if that's the case, you need to have sufficient evidence for each of them independently. So, subtypes. Well, I talked to you about a single episode of depression versus recurrent subtype of depression. I talked to you about seasonal affective disorder, which is a seasonal onset of depression. Now, most people, when they think of a seasonal depression, they think of the winter, what is referred to as the winter blues. But I'm going to tell you that it isn't always the winter that causes depression. And in fact, there are some people who have what's called the summer blues, right? So we have to be mindful that even though the common case is winter, any season can have depression linked to it. Now, if we're going to diagnose a seasonal depression, we have to have evidence that this has occurred in at least 2 years. Why? Because we have to have a track record. So if the winter is making you more depressed, then I need to know 2 consecutive winters that this has occurred in order for me to feel confident that it actually is a seasonal onset. Catatonic depression. So this happens in severe cases of depression where a person can feel almost immobilized or paralyzed to the point where they can't speak or move. And I only had one case like this, but it was actually a case of bipolar disorder. And when the person was either manic or of normal mood, they were able to speak. but when they had a depressive crash, they had a hard time speaking altogether. And it's an interesting experience if you ever see that. Postpartum depression, the symptoms have to emerge within the first 4 weeks of giving birth. Now, postpartum depression is a significant problem, and we estimate anywhere between 1, sometimes 2 out of every 10, anywhere between 1 to 2 out of every 10 women who give birth will experience postpartum depression. And if you were to paint a picture post childbirth, the common picture is the mom holding the baby, looking with love into the baby's eyes. A person who has postpartum depression, it is possible that they don't even want to hold their baby. They might be angry at their baby. They may not feel bonded to their baby. They might feel, what's wrong with me? Why isn't it that I don't have a connection to my kid? All of these things can show up in a case of postpartum depression. Now, a large segment of people can have sadness post labor and delivery, but for postpartum depression, it's more severe and it's more continuous. So we're not talking about periodic sadness, we're talking about continuous sadness. We also have a melancholic subtype where a person develops anhedonia, where they're not feeling any pleasure or joy from their life. So there are different subtypes, and it isn't just diagnosing a person with depression, it's understanding their symptoms. And I'm not sure if I said this to you before, but I'll say it again if I did. There are 20 students in this class. I could have 20 patients diagnosed with depression, and each of those 20 patients, the symptoms will look different. So if all of you had depression, it is possible that it would all look differently. And that's important for you to know, because while the broad diagnosis is depression, we still have to treat people as individuals. We still have to treat the symptoms as they present for that person. And we have to be sensitive to that. So with all the subtypes and with only needing 5 out of 9 core features, it's easy for people to have a diagnosis and it look different from person to person. So we talked about the criteria for a major depressive disorder. I mentioned to you in the DSM-5, they added premenstrual dysphoric disorder. And your book doesn't put much emphasis on this. So what I did was I lifted the diagnostic criteria out of the DSM-5 directly, because I wanted you to see the language of the DSM-5. So in order for a person to be diagnosed with premenstrual dysphoric disorder, they have to have a minimum of 5 symptoms in most of their periods for a whole year. So at a minimum, we're talking about 7 out of 12 months where they have 5 features of depression that present themselves in the final week leading up to the period, and then they become, they decrease and ultimately become absent during the week after the period. So let's see, there's something in the chat. All right, so then how are specific symptoms like hallucinations from major depression differently than diagnosed other disorders? So it's a good question. When we get to schizophrenia, you'll see that people can have hallucinations and delusions for not just schizophrenia. We saw it could be with major depressive disorder. We saw that we will see it could be with bipolar disorder. We will see that it could be substance induced. We can see that people have delusional disorder without hallucinations. So when we think of psychotic features, I know you think schizophrenia or bipolar disorder, but those aren't the only conditions. And there are rules for diagnosis. So, Fan, the question you have, we have to have a certain number of symptoms in each category. And there's a reason why I say you need X number of features. It has to be due to this. It can't be due to that. So the whole purpose of going through the diagnostic criteria is we have to treat it like a checklist. And just having hallucinations in isolation is not enough to diagnose a person with any condition. It's not enough to diagnose with schizophrenia, mood disorder, etc. It's what are the other symptoms that coincide with a given feature. Fan, does that answer your question? Okay. All right.
Yeah, Professor.
You got it. So
Sorry. So
yeah.
What I was trying to ask is like, is there any specific like distinctions like between hallucinations like from one's disorder and like hallucinations from other disorders? Are there
No,
any nuances?
there's a lot of nuance, right? So in order to diagnose a person with schizophrenia, we're tracking the symptoms for a minimum of 6 months. There has to be both positive and negative features of schizophrenia. So that could be hallucinations and or delusions as positive symptoms. Now, positive doesn't mean good. It means things added to your reality, and additional negative features such as reduced motivation, social isolation, inability to take care of oneself, and so forth. So there are significant nuances, right? So it's not just a mood disorder. And here's another cool one. There is a possibility that an individual can have both schizophrenia and a mood disorder. And if they overlap sufficiently, there's a diagnosis called schizoaffective disorder, which is when there's sufficient overlap of schizophrenia plus a mood disorder. So there are guidelines to give a mood disorder. There are guidelines to give a diagnosis of schizophrenia. There's guidelines to give delusional disorder, brief psychotic disorder, and I could keep listing conditions that have psychosis as either a symptom or the core. So, but in the case of depression, it's a symptom. It's not the core experience. I don't know if that makes sense.
Yeah, thank you.
You got it. So back to premenstrual dysphoric disorder, we refer to it as a chronic condition. So we track for a minimum of 1 year straight. We're looking for a minimum of 5 symptoms to be present leading up to the period for most months out of the year. And then after the menstrual cycle, the symptoms ultimately disappear. So let's go through some of the symptoms. Now, again, you have to have a certain number of criteria. That's very, very important. So in category B, you have to have at least one, if not more, of the following symptoms. So increased lability, right? So these are mood swings or extreme mood changes. Increased irritability or anger, such as with interpersonal conflict. Increased rates of depression or hopelessness. Increased anxiety or tension, right? So you have to have at least one in part B. Or in criterion C, you have to have at least one, if not more, of the following symptoms. So between criteria criteria B and C, you need a total of 5, right? So we listed in B. Now in C, you have to have decreased interest in work or hobbies or friendships. So your usual activities, decreased concentration, lethargy or fatigue, changes in appetite, in sleep changes, feeling overwhelmed, and feeling bloated or physically tender. So if we look at this, some of these features, you'll probably say, hey, wait a minute, that is just a normal physiological reaction to the menstrual cycle. That is true, but it isn't 5 of these features, right? So you have to have 1 plus of B when I went back, and you'll see that in criterion B, these are more the psychological features of depression that we covered before. And then here are some additional physiological features as well. And then social components. So between B and C, you need 5 features. And as I said, it has to be most of the menstrual cycles in the previous year. So at least 7 out of the 12 consecutive months. So you're tracking it. If a person says, I feel moody in the lead up to my menstrual cycle, we're not going to jump right to, oh, it's PMDD. We're going to either ask them to do a retrospective for the last year, or we're going to ask them to track it. And as we have more data, we might feel more confident in the diagnosis. So that's criteria B and C. Now, D suggests that there has to be some level of distress or dysfunction. That's with all of the cases, and it cannot be better explained by an exacerbation of other diagnoses, right? So that's important. Now, even if we do a retrospective of the last year, we're still very cautious, and we still track at least the most recent 2 periods as well, looking forward. And it can't be due to some kind of medication related matter. So before we give the diagnosis of PMDD, we're very cautious to make sure that something else is not happening. In the chat, the slide is not in our PowerPoint. Can you upload it after class? I certainly can, of course. So that's the criteria. Now, one of the really interesting research studies demonstrated that the rates of PMDD range anywhere between 1.8 to 5.8%. And we know that when we do retrospective reports, the rates are higher than if we actually track it. Now, I find that this data is very, very powerful. And the reason why I say that is because it is not uncommon for people to engage in casual sexism, where people would say, oh, she's very moody, she must be on her period. And that's an unfair statement to women, right? Because the vast majority of women do not meet the criteria for PMDD. So we're not going to over pathologize a person because they have a menstrual cycle, right? But it also does give some credence to people who are struggling with a mood disorder. So there is the need for this diagnosis when appropriate, but we don't want to weaponize a diagnosis to pathologize women either. So that number of 1.8 to 5.8% is pretty powerful. Okay. So we talked about major depressive disorder, the subtypes of major depressive disorder. We talked about premenstrual dysphoric disorder. Now let's talk about persistent depressive disorder. which used to be referred to as dysthymia. So persistent depressive disorder is very similar to major depressive disorder. The symptoms look the same, but the number of symptoms that need to be triggered is 2 instead of 5. The length of time is longer for persistent depressive disorder. It's not 2 weeks, but it has to be a minimum of 2 years. And even amidst those 2 years, you cannot have a gap of 2 months of non-depression or non-depressive symptoms. So that's why I describe it as kind of low-grade chronic depression. And when you see the typical profile of a person with dysthymia, therapy looks like just helping them cope on the day-to-day, right? So it isn't that they have this major crash and then they're normal and there's no symptoms. There are going to be symptoms throughout their life, and the goal is to teach people how to navigate these symptoms so that they can function, and then it doesn't turn into a major depressive episode, right? That's really the goal, is to keep low-grade chronic depression as low grade. Now, because it's a unipolar condition, there could be no manic or hypomanic symptoms. I will define manic and hypomanic when we talk about bipolar disorders, but a very quick definition of time, a manic episode is a week or longer, whereas a hypomanic episode is 4 days to about 6 days. So anything under 4 days is not a hypomanic episode. Anything a week or longer is a full manic episode. Okay. So if you were to ask me, where does depression come from? Well, it comes from a lot of different places. And if we were to look at biology, from a biological point of view, we know that there is a genetic component. How do we know this? From twin studies, adoption studies, and genes, right? So if we were to look at concordance rates, now concordance rates by definition are as if one twin has a condition, what is the probability of the second twin having the same condition, right? So the overlapping conditions. Now, with identical twins, the rates of depression, if one twin has it, the other one's going to have it, is about 46%. Now, keep in mind, when we went over the general population, in a given year, it was about 6%, and across a lifespan, it was 17%. But identical twins or monozygotic twins, it jumps all the way up to 46%. So it's a higher rate. And even fraternal twins, which have the same genetic similarity as like siblings, is still higher than the general population. So twin studies tell a story. Adoption studies tell a story. We see that based on adoption studies, people are more like their biological parents in terms of acquisition of depression. So even if a person was adopted into a family that doesn't have depression, these children are still at greater risk of depression due to the biological predisposition. We also know that the 5-HT T gene, or transporter gene, which is on chromosome 17, is linked to it. Now, when we talk about treatments in another lecture, we're going to talk about medication and selective serotonin reuptake inhibitors, or SSRIs. Well, why would an SSRI even work? The answer is simple. At baseline, we know based on the 5-HT transporter gene that there are low levels of serotonin. So we want to increase the levels of serotonin to improve mood. By the way, 5-HT is the abbreviation for serotonin, if you're wondering. Now, neurotransmitters, we talked about serotonin, but there are other neurotransmitters linked to it. Norepinephrine is linked to it. To some degree, dopamine is linked to it. But if you look at it, for major depression, serotonin is the primary neurotransmitter, and it serves as a neuromodulator. Basically, it serves to regulate the other neurotransmitters. So decreased serotonin coupled with decreased norepinephrine or decreased dopamine is going to result in depression. Whereas if you have serotonin increase norepinephrine levels or dopamine levels, that's going to increase the likelihood of a manic state. But the neurotransmitters, these are your common ones. And hormones. If we look at hormones, we know stress is linked to depression. So high levels of cortisol is linked to depression. Low levels of melatonin is linked to depression. Now, remember that from a molecular point of view, melatonin and serotonin are very, very similar. From a chemistry point of view, they're almost identical, right? So having low levels of melatonin could increase the risk of depression. Now, you'll notice that people who struggle sleeping, there is a recommendation of melatonin as well, because melatonin is what signals it's time to go to bed. So we might argue some of the sleep disturbances attached to depression is due to melatonin. From a structural point of view, we see that with major depression, you could have increases and or decreases in blood flow in the prefrontal cortex. We don't know why. So if you ask me, well, why does it work that way? We're not sure. We also know that there is decreased functioning in the hippocampus. So the hippocampus is one of the few areas of the brain where we have meaningful neurogenesis. So the regeneration of neurons. And with depression, it impacts the development or creation of more neurons in the hippocampus. So what does that do? It affects one's memory and increases the likelihood of accessing negative emotional memories. We also have increased activity in amygdala. I told you that the amygdala was linked to emotions, things like fear and rage. So the heightened emotionality could be linked to the amygdala. And then we see Brodmann's area as kind of like a depression switch on the cortex. So decreased activity in area 25 results in less depression. All right, so that is the biological explanation of what causes depression. If you were to go back to our theories of mental illness lecture, we went through a whole host of different paradigms. What would Freud say? Freud would say depression and grief are very similar. And in fact, if we were to look at it, it all starts with some level of real or imagined loss, which causes one to regress. And that regression leads to turning inward and turning it into like a personal loss. And then as you engage in introjection, that's going to lead to ultimately depression, at least from Freud. So we have a defense or a couple defense mechanisms at play, which stack up and result in depression. From a behavioral point of view, the explanation of depression is based on pleasure, right? So pleasure and reinforcement. As we get older, we get fewer opportunities for pleasure and reinforcement. So as we're getting less reinforcement, we start to stop doing behaviors that we used to like. And ultimately, we stop the behaviors altogether, and then the loss of gratification leads to depression. So, one of the treatments, as we talk about a behavioral point of view, is called behavioral activation, which is to help a person figure out what were some of the activities they used to really enjoy doing and how the depression resulted in them stopping doing those behaviors. And then we encourage them to re-engage in those behaviors and focus on the enjoyment itself. So that's a tactic we use. From a cognitive point of view, I mean, we will start with Aaron Beck. Aaron Beck puts an emphasis on the cognitive triad, right? So if a person has a negative view of, their life, themselves, and their future, right? Hence triad, 3 parts: view of one's experience or life, view of oneself, view of one's future. It is possible to become very hopeless and depressed. Another cognitive error that's linked to depression is perfectionism, feeling that one needs to be perfect in order to be good at something or to have any kind of value. Now, what's interesting is these mindsets of perfectionism, or that my self-worth is linked to my performance, is also explained by the humanistic and existential model as well. We can also draw faulty conclusions or errors in thinking, and we could have knee-jerk or reflexive negative thoughts, which we call automatic thoughts. According to Aaron Beck, if we can identify these things, we can rewire our thoughts. We can challenge the thoughts. We can engage in what's called cognitive restructuring. And by engaging in cognitive restructuring, we actually are able to address the problem of depression. Now, Martin Seligman is known for his famous studies on learned helplessness. So learned helplessness is linked to depression, and I'll explain what learned helplessness is. The idea that one cannot escape an outcome or has no control over an outcome is learned helplessness. Now, in Seligman's study, he had dogs divided into categories, where some dogs were put in a category of what's called an avoidable shock, and other dogs were put in a category of what's called an unavoidable shock. And basically, the avoidable shock condition was that the dogs, if they stood where they were, there was a mild electrical shock that would come through the grid where their paws were. But if they jumped to the other side was not wired for electricity. So by jumping to the other side, they could avoid the shock. And the dogs that were in that condition quickly learned to jump to the other side. The dogs that were in what's called the unavoidable shock condition, they got shocked whether they jumped on the other side or stayed. So if you stay and you get shocked, or you jump to the other side and you get shocked, what's the point in trying anymore? Well, that's learned helplessness. So what was wild was, after these dogs learned that no matter what, their actions didn't matter, they stopped trying. And Seligman then put them in a scenario where they were able to jump to the other side and avoid shocks, but by the time they developed learned helplessness, still they never tried. And cases of domestic violence are like this, right? So you might ask a person, well, why do you stay with an abuser? Why would you stay with a person who engages in physical assault? The answer is learned helplessness, or one answer is learned helplessness. By the time a person develops learned helplessness, they have tried to get out of that violent relationships several times, but were unsuccessful. And no matter what they tried, they just wound up back with their abuser. So eventually, a person who feels that I'm stuck in this relationship is going to stop trying to get out. And only through therapy can we help people realize that learned helplessness is set in. So, but we talk about domestic violence, but depression is the same thing. You know, people stop trying and motivation decreases when people feel like no matter what, it doesn't result in something positive. So, control. If we were to look at 3 spectrums of how people determine whether they have control or not, we look at an internal versus an external cause, whether the experience is global or specific. Is this going to happen in every scenario or just this scenario? Or stable or unstable? Is this going to happen all the time or some of the time? If a person made internal, global, and or stable attributions, they're more likely to acquire or develop learned helplessness. Whereas if a person develops an understanding that there's an external cause, it's specific to a certain set of conditions, and it's not all the time, then they're going to continue to try. They're going to feel like they have more control over their outcome, and they're less likely to develop learned helplessness. So that is the cognitive point of view. So I'm going to stop the recording here, and then I'm going to do a separate recording on bipolar disorder.